Yes, sir.
Good evening to everyone. I'm Dr. Onkar Swami on behalf of MQ Pharmaceuticals Limited. Welcome you all in this HIV update. Today, we will be discussing on clinical updates from CROI 2022 conference. And to take us this update, it's our pride, privilege, and honor to welcome Dr. N Kumarasamy, sir. Sir is Chief and Director of VHS Infectious Disease Medical Center at Chennai in India. Sir is also a director and site leader for the Chennai Antiretroviral Research and Treatment CART clinical research site of US National Institute of Health, which conducts multiple therapeutics and prevention clinical trials. Sir has been a clinical investigator for many prestigious research projects with Brown University, University of California, Harvard University, University of New South Wales in Australia. Sir has been a clinician and researcher in infectious disease with more than 25 years of experience and authored more than 400 manuscripts in peer-reviewed medical journals. Sir has been an advisor, expert panel member for WHO ERT Treatment Guideline Committee and a clinical advisor to the Clinton Health Access Initiative. We are always feel proud to associate and work with Dr. N Kumarasamy, who always been a friend, philosopher, and guide to us. So I will not take much of time, and I would like to hand over this session to Sir so that he can take us for the recent update from CROI 2022. So over to you, Sir.
Sure. Thank you very much, Dr. Onkar, Mr. Balaji, and everyone, the organizers, for today inviting me to do this CROI update. And good evening, everyone, and thank you for joining this webinar on a hot Saturday evening. I'm going to share my slides. Dr. Onkar, you can tell me whether you are able to see the slides.
Yes, I'm able to see the slide, and it's perfectly all right.
It's moving, right?
Yes.
Okay, that's fine. So what I'm going to talk to you today in this webinar in the next 35 to 40 minutes is going to give you an update from the conference called Retrovirus Conference, which many of you know that every year it happens in the United States, where the highest science from HIV research is being presented. So this year, this happened in the month of February. And due to this COVID pandemic, it was like purely a virtual conference, not even a hybrid, purely virtual, where no one were able to be attended in person. And again, particularly for our physicians in India and other parts of Asia, it was exactly, since we live on the other side of the planet, very hard even when some of you registered to follow some of those updates. So I thought for you, since you're all practicing clinicians or researchers, I will not be able to talk everything what happened in CROI because this happened on 4 days or 5 days over a period of 2 different weeks, and hundreds of different studies have been presented. So I have picked up around 6 to 7 key studies, which will be very relevant, especially for clinicians practicing in India or in other lower and middle income countries, which may impact on your clinical practice. And some of the things what I'm going to talk may not impact today, but it may impact in the next couple of months to couple of years because of the new evidence coming up to update our current guidelines. So at the end, we can have the question answer sessions where you can type all your questions at the chat, and our moderator, Dr. Onkar, will moderate this session and will put the questions to me. So I think with this brief introduction, I like to show, because in every presentation, I always walk through the guidelines, what we use or the countries use to adapt. It's something what WHO recommended, which you all practice in your routine patient care. So we start our patients on TLD or tenofovir emtricitabine dolutegravir. Also, the guidance shows where you don't have access to dolutegravir or you cannot use, you can also use efavirenz 400. But again, that's not widely available. And again, you need to do a resistant testing. Hence, I may not recommend that. And our earlier efavirenz 600 is recommended only in a special population because of the toxicities. And also the earlier guidance also showed in special population, instead of tenofovir, You can also use a TAF, tenofovir, which again I'll walk you through. What will be the benefit and what will be the harm one can come through. Also, the WHO gave guidance on switching from first-line failure to second-line, or people who are already stable on a TLE combination, to the dolutegravir-containing, combination. I think based on the Dawning study, which I think I presented to this group, or some of you would have been attended that webinar in details about the Dawning study, where someone who's been failing NNRTI-containing therapy, in a regular practice, we switch them to 2 NRTIs, which we optimize NRTI. For example, someone who's on tenofovir lemivudine, we change to AZT3DC, or someone who's on AZT3DC, we change them to tenofovir lemivudine. And along with that, we use one of the boosted PI, preferably boosted artesunate or lopinavir. So following the Dawning study, the guidelines also recommended you can use dolutegravir instead of the PI if you're initiating therapy or if efavirenz or nevirapine failed. But on the other hand, the guidelines also recommended you need to optimize the NRTIs from whatever you are given as a primary therapy. So what the guidance said was the one what you have been practicing, someone who is on TLE, if they have been virologically been failing, now again, the viral load cutoff was further changed to 50 copies, the recent one, which you would have seen in 2021. We changed them from tenofovir to AZT3DC and dolutegravir. So that was the things, which happened in the last guidelines. Then again, based on, because there are several dolutegravir monotherapy trials have shown, it has not been efficacious. So if someone is on tenofovir lemivudine, if they fail tenofovir, develop mutation as well as to 3DC, there was a threat that dolutegravir, if you recycle, probably it's a monotherapy may not work. And because of that threat, now we changed them to AZT. So that happened based on one of those large observation study, which many of us got involved, called TWINAQT study, which showed anything from 39% in Asia to 55% in sub-Saharan Africa when someone fails tenofovir can have K6PR mutation. And because of the risk, this guidance was made. But on the other hand, as practicing clinicians, many of you know that AZT has got its own risks. So it can produce severe anemia, body shape changes, severe lipoatrophy, and several metabolic complications, and also been proved very well in randomized clinical trial done in research limited setting called PERD study, ACTG 517, very long back, I will show as a result. We moved this out of those first line from all the guidelines. So now the question is, can we recycle, because in the context of AZT toxicities, tenofovir to tenofovir again as part of the second line? To answer this, the study called NADIA, which was earlier, initial 48-week results were earlier presented at the IAS conference 2021 last year. Now the updated results were presented at this concluded CROI at the week 96 results. Now you can see what is this study on that. So before I go into that, again, to set up the background, the WHO earlier recommended when you change from TLE, you optimize 2 NRTIs to AZT. That's because they can have potential, resistance. But on the other hand, the NADIA study, the 48-week results showed that earlier, both the tenofovir 3DC is non-inferior to AZT, 3DC. So that was a 48-week results. And today, I'm going to give you the updated one on 96 results of NADIA, which is very important for the future guidelines to change, and that's also for practicing clinicians to make your make this as an impact in your practice. I want to spend 30 seconds on this design of the study. Very nice study. It's a large multi-center. Happened in sub-Saharan Africa, where patients who have been received TLE and who had been failed with a viral load of more than 1,000 copies at 2 different times after 6 months of therapy. They were randomized into 2 different types of randomization. First randomization is when they failed, the group received either dolutegravir or boosted darunavir. Here, darunavir was 800, 100 milligram, again available as a co-formulated tablets in India, from generic market. Next randomization is people who are randomized to dolutegravir. They have also been randomized. One arm recycled the tenofovir 3DC, another arm changed to the earlier guidelines of AZT 3DC. So there is another randomization there. Again, the darunavir ritonavir arm also randomized to recycle tenofovir 3DC and as well as another arm changed to AZT3DC based on the guideline. Again, the 48-week data earlier very clearly shows dolutegravir was non-inferior to darunavir-ritonavir. Also, it shows tenofovir was non-inferior to AZT. But that is a 48-week data. Always in HIV practice, we give this therapy lifelong. And again, many of these antiretroviral that we start, they take considerable number of years, 5 years, 7 years, or 8 years by the time they develop a resistant change. So any long-term results will give a lot of confidence to the practicing clinicians as well as to the patients. Also, will make a good impact on the guidelines committee because they look into all those evidence before they change anything. So here again, the baseline characteristics between the two different groups is almost similar. There is coming to the age, sex, and the country, BMI, Hepatitis B serology, and as well as CD4 and the baseline viral load. So there are no confounders on this. Again, when they looked into the ART history as well as a baseline resistance, also there is no difference in between, any of those different arms. Hence, as a result, there is no confounders, for all this. Coming to the week 98, 96-week efficacy between different arms. Here, first I'm going to concentrate between dolutegravir and the boosted darunavir. If you see this, between these two arms, there is no difference. It's not statistically being significant. Both are same. So that means for your second line, when they are been failing tenofovir, lamivudine, and efavirenz, either you can use dolutegravir or darunavir-ritonavir. And also this study will be a good case note. If you got a first line on TLD, they fail. You don't want to recycle DTG, you can use darunavir 800 with 100 milligram ritonavir as part of the second line. So this is something this study also said. But again, the primary objective of that study is not just that alone, but on the other hand, to show between tenofovir 3DC and AZT3DC. In this very clearly shows that when they looked at the virological efficacy of less than 400 copies, it has been statistically significant in a way that tenofovir has been superior. So we didn't expect that when the trial started, but it clearly shows it has been superior. Further sub-analysis, this is very, very important practice, because these are the studies can be done only once in a lifetime, which changes the critical guidelines. So between dolutegravir and darunavir, there is no difference in terms of virological suppression. So again, either with the tenofovir arm or with the AZT arm, doesn't matter. Both have been very robust. So it's been very clear that both can be interchangeable to that. But on the other hand, here, if you look into that, between the patients who had developed a baseline tenofovir resistance, where they have recycled tenofovir, as compared to AZT, where there is higher virological suppression in tenofovir. Which is not statistically significant, but again, we expected there will be inferiority here with the tenofovir because of the K60R, but that did not happen. So that means the arm of dolutegravir and darunavir is so robust that even if they have K60R mutation, tenofovir works very well. But on the other hand, when they looked into the absent between K60R mutation, where tenofovir did very well, eventually it should have to do well, but AZT did badly. So that means tenofovir is superior. Either you recycle with they have a K60R mutation, or if it has been absent. So it's been very clear that it worked very well. Again, when someone has got a M184V mutation, and again when it has been absent, tenofovir worked very well. Again, when it has been present, again tenofovir did extremely well. This is something shown in this particular analysis. On patients who had failed, of course, in every clinical trials, like in normal our observational data, we see failures. When patients failed and they looked into those dolutegravir integrase mutation, which is again much higher in the AZT3DC arm as compared to tenofovir 3DC arm. This again very clearly shows tenofovir 3DC with dolutegravir for switching to the second line, even recycling tenofovir 3DC, it's been fine based on these guidance. Again, coming into the adverse events, there is nothing major to show that these dolutegravir or darunavir caused more harms. Only in AZT arm, the numbers are more in grade 3 or 4, mostly because of the anemia, nausea, and as well as the body shape changes. So this pivotal NADIA study, I will call it a landmark study, well conducted of week 96, very clearly concluded, stating that there are 2 NRTIs with dolutegravir non-inferior to booster darunavir, that is 800 with 100 ritonavir, and 2 NRTIs who experience NNRTI failure. So we have got both regimens available in India through our generic manufacturers, and it might be a good case note to use that. And also, 2 NRTI-based dolutegravir can be used as a second line, even if NRTI is predicted to have no activity. So that means when tenofovir had failed in the first line with the efavirenz, still you can recycle that. Also, 2 NRTIs DTG can be used where resistant testing is not available, but DTG resistance can be a concern. But on the other hand, if it is not available in a public health setting, just recycle it. And darunavir ritonavir 2 NRTI has efficacy equivalent to DTG and 2 NRTIs in second-line treatment without concern for resistance. But this study very clearly shows tenofovir 3DC was superior as compared to ACT 3DC. I think that's a very carry take-home for clinicians in your practice where you can recycle tenofovir 3DC. This was also been supported by another study, again presented at this CROI, called VISEND. This study happened in Zambia, where patients who had failed in NNRTI been switched to either protease inhibitors or dolutegravir, and NRTIs were recycled. So this is a design of the study where 1,200 patients who had failed either tenofovir 3DC, efavirenz, or a nevirapine combination, they were randomized into 2 different arms. One arm, they have been actually have less than 1,000 copies. So they just wanted to change them to either tenofovir, lamivudine, and dolutegravir, or TAF, FTC, and dolutegravir. And another arm is patients who had failed, that is more than 1,000 copies of viral load in 2 different measurements, where they had received 4 different randomization. One arm received tenofovir, lamivudine, dolutegravir recycled. Another arm TAF, FTC, and dolutegravir. Another arm received AZT 3DC, lopinavir, ritonavir. That was a standard of care because of the guidelines in sub-Saharan Africa. Also, in some regions, they use AZT 3DC boosted artesunavir, which again commonly used here in India. So again, the primary endpoint is HIV RNA less than 1,000 copies at week 144 by the FDA snapshot intended to treat analysis. Here I am presenting the week 48 data, which has been presented at this retrovirus conference. Again, this is a phase 3 study happened in Zambia. Again, the baseline characteristics has been similar. I don't want to go into the detail for various different characteristics. There is no opportunity of a confounders. And when you look at the virological efficacy at week 48, so if you look into those arms, where people who have got a suppressed viral load, where they have also been moved to TLD or TAF-FTC, they continue to have the equal same virological suppression. When someone who has got more than 1,000 copies, if you recycle tenofovir or move to TAF along with dolutegravir, they have a higher virological suppression as compared to someone who had used AZT 3DC and lopinavir. In Africa, they use a lot of lopinavir because that's widely available as compared to artesunavir. This is again because of the toxicities to lopinavir and also the pill burden. And again, AZT 3DC ritonavir, equally fared well. But on the other hand, don't underestimate the AZT toxicity which is shown in other studies. So DTG plus tenofovir 3DC was non-inferior to TAF, FTC, and DTG, regardless of the baseline viral load, either less than 1,000 or more than 1,000. And both tenofovir, lamivudine, and dolutegravir, and TAF, emtricitabine, dolutegravir is superior to PI with the ritonavir arms. So very important here is the weight changes, which many of you know that now one of those concerned with the integrase inhibitors, and not just with the dolutegravir alone, but even with other integrase inhibitors as shown in studies from North America, is a weight gain. And also there are data being shown from sub-Saharan Africa, particularly from a study called Advanced Study in Johannesburg, where higher weight gain was shown, particularly in arms in women with the TAF, emtricitabine, and dolutegravir. So again, in this particular study where the weight data was fully available for the randomized patient who had more than 1,000 copies, where higher weight gain had been seen, particularly in women, who had received TAF, FTC, and adult. It's again in very supportive evidence of weight gain issues shown in the advanced study in sub-Saharan Africa. Again, this study happened in Africa. So again, we need similar studies or even good observational data from our Asian population, where are we going to see the similar things uniformly, or only one or two cases we are going to see about these weight gain issues. But that was not seen with the AZT3DC in lopinavir and as well as in artesunavir. So this particular VISEND study concluded stating that recycling tenofovir 3DC along with dolutegravir, or from TAF FTC to dolutegravir when someone fails TLE is been superior. Higher weight gain had been seen receiving with the DTG and most with the TAF containing regimen. And again, the investigators very clearly concluded that these NRTI, which are used in the first line with tenofovir lamivudine, can be recycled. So I think following all this, again, I'm going back in the earlier guidelines. We used to optimize these NRTIs from tenofovir to AZT or AZT to tenofovir. So now in your practice, there will be an impact will happen where you can still recycle this. Tenofovir 3DC efavirenz, if they fail, you can recycle to tenofovir 3DC to dolutegravir. Now we have two good studies, NADIA and VISEND. There is also one other study we have been involved. The results are not ready yet, called depth study, which will also, the guideline makers will wait for the data to make a huge impact on. This is something what you can use in your practice, because AZT in the second line can have a pill burden, because we have a TLD as a fixed dose combination, and also can have huge toxicities with AZT because of the metabolic and anemia and body shape changes. And having said all those, we all know about this tenofovir issue, which already been shown. Our group has already shown about the tenofovir renal dysfunction from our cohort, as well as our Asian colleagues from the TWINAQT Asia cohort, which have consisted of cohort patients from India, Thailand, Cambodia, China, Hong Kong, Japan, and Malaysia, also had shown similar renal dysfunction on a long run. Then you may ask a question, why not I use a TAF? Again, we discussed now that TAF along with dolutegravir can have a weight gain issue, which was been seen in a couple of good clinical trials. And also advanced study very clearly showed about that combining TAF and dolutegravir can have the weight gain as shown here. But this is a study which is long back been published 3 years back, where you have shown, particularly in women patients, between TAF and tenofovir with dolutegravir, TAF has got a higher weight gain, which has already been seen. And having said this, can you drop one other drug out, the offending drug like tenofovir? So European guidelines and the DHSS guidelines have long back given some guidance where, because of this toxicity, you can drop a drug when someone who's got undetectable viral load. So, but on the other hand, they had used a lot of other drugs like TIs and lamivudine, or they also had used dolutegravir and rilpivirine. It's been available as a single tablet and USFDA approved called Giluca. It's all they had been used. But now, in the context of dolutegravir, where can we use any two-drug therapy? There are several studies had been done. I don't want to go into the full details of that, but there is one particular trial, GEMINI 1 and GEMINI 2. So this is that study, long back being published, which has shown either people who are initiating therapy or people who got suppressed, where they are randomized to either continue all the three drugs, or they dropped tenofovir, continued only dolutegravir and the lamivudine, where they've shown comparable efficacy. And following this, US FDA, in 3 years back, approved this combination of lamivudine and dolutegravir as a Dovato. But at that time, there are only very few evidence had happened, and we didn't have many follow-up data. And because of that, there are many guidelines being recommended on that, because as I said earlier, in HIV, we need longer data so that it will be safer on patients, particularly on efficacy point, as well as adverse effect. Again, it's a known drug. So in this conference, there's a very nice study that was been presented called SALSA. So in this study, they not only looked into those long-term efficacy of these dolutegravir and 3DC, but also there is a potential concern earlier happened in various discussion forums. When someone who's on tenofovir, lamivudine, and dolutegravir, there were possibilities they can have lamivudine baseline resistance, which could be anything from 3 to 10% from some of those earlier baseline studies. So if that's the case, then when you move to this arm, when you remove tenofovir, again, Dovato can be potentially a monotherapy. So in the SALSA, what they did is, so patients who had been recruited at baseline, they also tried to look at the baseline archived resistance. That means even if they have suppressed viral load, we have now some molecular assays where you can find whether they have archived any drug resistance, where they looked into those, particularly 3DC. Again, SALSA is a phase 3 study which showed a non-inferior efficacy of a switch to Dovato 3DC versus continuing all the 3 drugs, and had shown good virological suppression with the DTG 3DC in the week 48 data, which was already been presented and published. So in this particular analysis, which was presented, they looked into those baseline genotypic resistance on looking at those archived pro-viral DNA. We have a molecular technique, even if they have suppressed viral load, we can see whether they have any archived resistance mutations, particularly on M184 mutations, so which was not initially known about that. So in this analysis, which I'm going to present, have investigated what will be the impact of this baseline archived resistance, especially in response to HIV RNA less than 40 copies where target not detected. So this is a design of the study. It's a large multi-site study where 493 participants were recruited. They switched, one arm continued the 3 drug when suppressed viral load. Another one arm was switched to DTG and 3DC drop-in tenofovir. But again, all these participants scored a pro-viral resistant analysis, that is a baseline resistant testing of pro-viral DNA to particularly to the 3DC mutation, but also to the other mutations. So this is a baseline characteristics between the different arms, which has been very similar. And also there are variety of mutations had been seen at the baseline, all those being enumerated here. Here, particularly, you look at that M184V mutation, their mutation to 3DC, which is very relevant when we talk about DTG 3DC, which in the arm of DTG 3DC, where there are 5 participants, and in the 3 drug combination, there are 4 participants that had M184V mutations. And when they looked into those analyses at week 48 with baseline resistance of HIV RNA copies, there is no impact had seen when someone has got a M184 mutation suppression. So even if they have archived mutation, a combination of lamivudine and dolutegravir was been efficacious and continued maintain the virological suppression. So this again is a very important study where this concern was there earlier, and because of these particular data, now we are rest assured that even if he got a 3DC mutation archived, this works, because this particular study very clearly shows that 3DC DTG, despite having baseline 3DC mutation, it worked. So DTG 3DC as switch strategy in patients with virological suppression can be done, using this SALSA data. How relevant for you practicing clinicians? As many of you know that this particular combination is now being available from these manufacturers as TWINAQT, as 3DC DTG. Some of you might be using this. So this is another drug where you can use it if you feel that the tenofovir is going to develop a toxicity where you don't want to use staph, or where you don't want to use abacavir as another 3rd drug, where this particular combination can be used. Now we have very robust data on that. Again, use this in a patients where they have a suppressed viral load. And again, once you start using, repeat a viral load within 2 to 3 months, because if at all, if they're not going to act immediately, you know that whether the virus will come out. That means then you may have to use tenofovir for another 3rd drug. Hence, in your practice, we strongly advise to repeat a viral load within 3 months to show that, okay, they are still suppressed. Don't use in any patients who are hepatitis B co-infected. So that means if you're going to use this TWINAQT, where you have to do hepatitis B serology. As you all know that tenofovir lamivudine should be used when someone is co-infected with HIV and hepatitis B. Hence, it is not recommended in hepatitis B infected. If you want to use it, you also have to use another drug for hepatitis B along with the lamivudine. And in TB patients, as many of you know that TLD, today we doubled the dose of dolutegravir. But again, we don't have a good data of doubling the dose along with the 3TC in the context of rifampicin. Hence, even along with the TB co-infected patients, not been recommended. In other populations, where you feel that they are well suppressed with TLD, and now you feel that they can develop a toxicity to the kidneys or the bones or TAF you don't want to use, then probably this TWINAQT could be a combination, because it is right now available in India, where you can use it in your practice. So moving to the other areas now, as many of you know that many of our patients, they don't want to take this tablet every day. So I have patients today living 25 years on ART. We have been following them for years and years, more than 2.5 decades. Good suppressed viral load. They keep asking me when I can stop the medicine. I don't want to. They have been pill fatigue, or they know some of them feel that they don't want to take this tablet in front of their family members because they are not aware of this HIV status. Some of them can be travelers. Taking them every day, would be a issue. In that instance, can we give some type of long-acting injectable every 2 months or 3 months or 6 months? Now we have got some few drugs being approved for use. One of the drug is called cabotegravir. Some of you know that it's been available as an oral tablet, and also has been developed as a long-acting intramuscular injectable with a half-life up to 40 days. Also rilpivirine, which is an NNRTI, it's been available as an oral tablet, already approved by US FDA and been available as a NNRTI for first-line therapy. Also been now developed as a long-acting injectable with a half-life up to 3 months. So now, based on a study called LATE-2, I will show one data on that, and as well as 2 other studies called ATLAS and FLAIR. It's been already been approved by the US FDA, and as well as in the developed world guidelines. In someone who has got a suppressed viral load, you can use this combination of long-acting cabotegravir and long-acting rilpivirine as 2 separate injections, not available as FTC, 2 separate injections under the name of called Cabanova. It's been already been approved. Also, I'd like to tell you in this webinar, I will not talk anything about the prevention aspects because just for want of time. So this long-acting cabotegravir, it's also been approved as a pre-exposure prophylaxis, because of based on the study called HPTN 083 and 084. Again, I'll not be speaking today. Probably we can have another webinar another day on particular aspects. So here, this ATLAS is, the LATE is a study which earlier showed this every 8 weeks dosage, which is non-inferior to every 4 weeks or every day oral therapy, and fewer adverse effects. Rilpivirine has to be refrigerated. Also, FLAIR is a study last year at the World AIDS Conference. It was been presented, stating that every month dosing is better. And following that, US FDA also approved this dosage of every month of injectable. Again, many times when your patients who are on suppressed viral load, you see them every 3 months or every 6 months, and they take the tablet. Calling them every month at your clinic to give this injectable can be a little issue for the patients, as well as for you also. Probably, you'll have a large number of patients you may have to see every day if they want to come every month. So here, this ATLAS study, where they used every 8 weeks, and also they compared with the every 4 weeks. So again, this data very clearly shows every 8 weeks, both in the intent to treat, as shown by this bar chart in the virological suppression, where y-axis proportion of the patient got a virological suppression, and which is been, and this green color one is on patients who's got per protocol virological suppression, which is again a non-inferior to every 4 weeks, which has been earlier been recommended. And in the follow-up data of week 152, again, as I said earlier, we need long follow-up data. There are few failures had been seen in week every 8 weeks, but again, there was not statistically been significant. Still, someone who's taking every 8 weeks, they have been continuously been superior. So when we compare between every 4 weeks and every 8 weeks on these various adverse effects, so again, it's widely known that every 4 weeks you need to give more injections, and as shown by these numbers, and they have more adverse effects because of injection site pain and all those injection site reaction as compared to every 8 weeks. It clearly shows that every 8 weeks is much better. Again, they also did some questionnaire studies and very clearly favored every 8 weeks are much better than every 4 weeks. So this particular, again, I will call a pivotal study, concluded stating that long-acting cabotegravir and rilpivirine injection given every 8 weeks remain effective through 152 weeks. So we have a long-acting data as compared to every 4 weeks. Thereby, it will impact the guidance in resource-rich settings And hopefully one day when these preparations are available in our settings. Again, every 8 weeks, now you have to bring the patients rather than every 6 months. Currently, our patients are taking these medications. So again, now we got a lot of other newer drugs in the pipeline. There's one such drug which showed a lot of promising earlier, which I had also spoken probably to you in the earlier meetings, called Retroviruses. But now that particular drug has been parked by the FDA because of an issue, particularly on patients who received that they did not have CD4 increase. There was a decline, but on the other hand, no other toxicities. Hence, I'm not going to discuss much on that on the development, but on the other hand, I like to talk to you about a new molecule which has shown very excellent data, but also has got some little issues. But on the other hand, the good data will drive this drug forward. It's called a capsid inhibitor. This is a drug called lenacapavir, where again, in previous meeting, I would have spoken to you about the week 24 data. So here again, this calibrated study got presented at the CROI, which was carried out in treatment-naive patients on initiating treatment, where there is a long-acting subcutaneous preparation. Also, oral tablet has been available, which can be given every 6 months, as a long-acting drug. So again, it's a capsid inhibitor. It's a new molecule, robust molecule. It can be used first line, second line, third line as a salvage therapy, even if they have been failed to integrase or NRTIs or protease inhibitors, which has already been shown very robust, high potency, and can be given either as a per oral or as a subcutaneous. And the earlier week 28 data very clearly shows that it has been very efficacious in treatment-naive patients. And in this analysis, which I'm going to present now, is an updated week 54, a little longer data on this long-acting drug. So this is the design of this study, very nice study. So this is a ART-naive patients who got a more than 200 CD4, who had detectable viral load. So they were randomized to 4 different groups, very interestingly. So group 1 is in patients who had long-acting lenacapavir subcutaneous every 6 months. And along with that, TAF emtricitabine had been given. There is another group who received the oral lenacapavir every day, and along with the TAF emtricitabine had been seen. Another one, they received what is called the so-called standard of care in the developed world, particularly North America, TAF, FTC, and bictegravir. So in this particular trial, in patients who received a long-acting lenacapavir, where when they have a suppressed viral load of less than 50 at week 16, they were all being switched to the maintenance of lenacapavir subcutaneous every 6 months, along with the TAF. Another group received lenacapavir subcutaneous every 6 months, along with the bictegravir. And patients who have been receiving everyday oral lenacapavir received along with the TAF FTC and their standard of care of TAF FTC and bictegravir in a continued. So 4-arm study with the primary outcome of viral load of less than 50 copies at week 54. So this is a baseline characteristics between the different arms. It's almost the same in terms of age, sex, and different ethnic grades and CD4 and viral load. And also when they looked at the virological efficacy, when they looked at that, less than 50 copies of intended treat analysis, it's been very clear that it's been almost been similar, where in terms of virological efficacy, there is nothing to show that subcutaneous preparation every 6 months has been inferior to others. It's totally been non-inferior. And also, since I said it's an updated week 54 from the week 28, it maintained the virological suppression from the earlier week 28 even up to the week 54. So that means very reassuring that on a long-term data of this long-acting drug of every 6 months subcutaneous preparation, again, it's so robust. It's a capsid inhibitor, which can work again against many resistant viruses, will be a good option. Also, they have seen these CD4 increase, and there were few resistance on patients who were failed therapy had been seen, very small numbers, but they all got resuppressed again with the integrase inhibitors and the 2 NRTIs, and it was not a cause of concern. So calibrate the primary analysis very clearly. Safety showed there is no major safety concerns. They had a few injection site reactions, which again it's been expected, but it's been much better than everyday taking oral tablets, where it's only every 6 months, again very minor. And again, pain and swelling had been seen, but all resolved on its own. There is nothing a major cause of concern. So this calibrate, where the study carried out on the ERT naive patients, very clearly on week 88, week 54, very clearly shows that all the arms where they received the subcutaneous lenacapavir arm, which is being non-inferior as compared to the everyday, oral therapy. And lenacapavir subcutaneous and peroral was well tolerated with infrequent, discontinuation. That way, this molecule is very robust. Again, the same molecule was also been studied in multi-drug resistant HIV. This is again a very important, particularly in a population like in India, where we have NNRTI failures, we are using integrase, we have PIs, and we might need other drugs. So again, a study, very nice study carried out called Capella, where the previous conferences presented week 24 data. Here we have the updated data. So again, in the earlier data, where they have very clearly have shown, even in a highly resistant population, where along with the optimized background, lenacapavir works and suppress the viral load with the week 26. Here, now I'm going to present the updated week 52 from the earlier week 26 data. So this is the design of the study. So these are all patients heavily retreated with the various class of drug. So where they have a higher viral load, repeat viral load, when it showed more than 400 copies, they were randomized either to receive initially oral lenacapavir along with the failing regimen for 14 days and subcutaneous lenacapavir for 52 weeks along with optimized background regimen. Also, there is a randomization where they use placebo along with the failing regimen for 14 days, then an oral lenacapavir for 14 days and subcutaneous. In patients who had less than 400 copies, we had a cohort which was called non-randomized cohort. It's just one single arm, where they use oral lenacapavir for 14 days along with optimized background, because there has been virologically success. And after 14 days, they received subcutaneous lenacapavir at least 6 months along with optimized regimen, where now 52-week analysis was being presented. These are baseline characteristics. There is no difference between the different groups. And again, looking at the efficacy between the week 26 to week 52, so it maintained the less than 50 copies and less than 200 copies. That's something is important to show that on a long run, this Capella drug, so in the Capella study, very clearly shows that lenacapavir maintains efficacy even in a heavily treated patients, particularly in MDR HIV. There is no major serious concern to side effects except a few injection site reactions were seen. There is no significant any other abnormality in grade 3 or 4 to discontinue this drug. And thereby this particular study concluded stating that even in a highly resistant population where lenacapavir can be very efficacious, was well tolerated, just one injection site reactions and as a result are discontinued. Hence, these studies clearly state that lenacapavir can be a drug very effective in treatment naive and treatment experienced person with HIV, and should also be evaluated in pre-exposure prophylaxis. Now, recently, there is a little concern about the lenacapavir, but may not be a concern for us. It's between the manufacturers, where they are also a little fine-tuning this molecule. So we'll wait for a little more data from them for the further development and as well as the usage in guidelines. So today, we have TLD. So we have some PIs. The future guidelines, treatment strategy, will be based on some of those data which I showed that how we can reduce a drug exposure by dropping tenofovir. Now we got good data on that there, we're reducing side effects. How we can use some other new agents like lenacapavir. And I didn't talk much about monoclonal antibodies. That's very interesting, which I'll talk a little bit on that, particularly on the reservoirs. And also certain long-acting preparation, because again, many of our patients may not like to take this tablet every day. So those people, these long-acting preparation, even every 2 months, now today it's available, can be effective. Also, every 6 months, lenacapavir one day might be available. So these are various options where you can have it in your mind while managing patients, which will have a huge impact on your clinical practice, because now we have good data being available. Now, a little moving away from these new drugs, as many of us know that in our practice, there are a significant number of our HIV patients, they have undetectable viral load. But on the other hand, and also they don't have any opportunistic infection, they are being clinically doing well. But there are few percent of them also have certain neurocognitive problems. So they may not be able to recognize things, forget things, find difficulty walking. I'm sure you all have seen this. So one of our collaborators, Scott Lettenter, who comes regularly to Chennai for our meetings, and he had a collaboration past with us. And now he proposed a study with the US NIH called ACTG 5324. And what they did in this study is patients who got a suppressed viral load, if you intensify with some more drugs, can you reduce its neurocognitive effect? So these are the things happens in people with even less than 50 copies. So what we do in our practice is sometimes we add some more drugs or add certain anti-inflammatories, antioxidants, antimicrobial, neuropeptidic drugs. We all have done that, nothing had worked. So in this particular trial, what they did was a little more intensified ART. So I'm going to talk to you what those intensifications. So it's a design of the study, randomized study. Patient who got a suppressed viral load, who got any cause of a neurocognitive impairment, so what they've done was they have added either dolutegravir with maraviroc, which you all know that which we use a CCR5 inhibitor, which is also being used in salvage patient available in India to the existing ART. Also add dolutegravir with the placebo to the existing antiretroviral drug, whatever they are on, or add dual placebo. So it's a 3-arm study where one arm will have dolutegravir and maraviroc, another just a dolutegravir, another one is just a placebos. The primary endpoint was here change in the Z score from baseline to week 48 based on different neurocognitive batteries has been done. These are all patients who got suppressed viral load. So baseline character is the same between the different arms along across the different things, including some of those different neurocognitive measures. But if you look into those results of this study, so what they've shown in that is over a period of week 48, there is no difference between the different arms. Either you use a dolutegravir alone or a dolutegravir with the maraviroc or just a dual placebo along with suppressed viral load ART. There is no change in the finding at all. So that means don't keep adding any more drugs. Not going to help you at all. So we don't have any drug right now at this time for these particular conditions in terms of ART. But there are a lot of other research happening, particularly on the neuroprotective drugs. So this is a very nice study, is very important, particularly in our clinical practice, because we are seeing increasing number of neurocognitive patients where many clinicians do not know what to do with this, where this study very clearly shows that continue the same ART. We can give all the other conventional supplements, exercise, and other supportive therapy. Don't keep adding more and more drugs. It may be more expensive to them as well as more side effects, because the study very clearly shows that it's not going to help them. Now I'm going to end my talk soon just to show that about can we eradicate and cure HIV, because this we have been talking about for decades now, so nothing major happening, but some interesting data have been presented at this retrovirus conference. That's an issue for you to use in your practice, but have it in your mind, probably one day might be available. So this is a study called eClear study. So these are all, this just to understand whether we can reduce the viral load in reservoirs. As we all know that when someone taking antiretroviral drugs and the virus gets suppressed, we measure in the peripheral blood mononuclear cells by doing a viral load. But on the other hand, in those patients, if you stop the antiretroviral drug, again, the virus comes back because the virus goes and hides in certain organs like lymph nodes, gut tissues, glial cells, and many of those other reservoirs, we call it as like in tonsils. And again, it comes back and causing the viral load replications. So here, whether do you have any drugs which can penetrate to these reservoirs, get rid of to make an effective cure? So no antiretrovirals have done this in the past. So now there are newly developed neutralizing antibodies, broadly neutralizing antibodies, we call BNAbs, have been developed. And also there are some other drugs called histone, cyclase inhibitor, we call it as HDI, the name called remdesivir. It's been also been developed, had been used for a variety of other cytotoxic interventions, where this drug has been used now as an experimental basis to get rid of the virus from the reservoirs. So this is a very nice study. What they used is they use integrase-based ART in ART-9 patients, and they have used along with the ART, they also use a broadly neutralizing antibodies on, again, is a long-acting one on days 7 and 21. And as well as they also, along with the integrase-based ART, they also had used romidipine, which is an HTA inhibitor. Also, they use integrase inhibitors along with that neutralizing antibody and remdesivir on days 7 and 21, remdesivir days 10, 17, and 24. Again, this is a very robust study where not only just measured the viral load, but also they did both plasma and intracellular HIV RNA as well as P24 DK to show that whether from the reservoir they are able to get the virus out. We're not going into the details. Excuse me. So it very clearly shows that the patients who are on these broadly neutralizing antibodies and along with the remdesivir, they have a higher DK, and also in the reservoir when they study that, they're able to get this out, particularly the integrated DNA. And also particularly they have seen in sub-analysis, they have shown in patients who are sensitive to broadly neutralizing antibodies. So as many of you know, in the COVID era, now some of those neutralizing antibodies, what we have seen in the first and second wave, cannot be used in the third wave in Omicron and others because of the resistant viruses. Similarly, in HIV also some of those monoclonal antibodies have been developed and broadly neutralizing antibodies. They also can sometimes become useless because of those resistance. Now here again, in this particular analysis, in people who have been sensitive, it had shown to be working on that. So among the cohort which received both these BNAbs and remdesivir along with the integrase containing therapy, there is a continuous undetectable plasma HIV and RNA in one participant where they have stopped ART, where there is no rebound even after 3.7 years. So again, I'm not asking you to use this in your practice. Something shows that there's something coming up now, where probably where you'll be able to interrupt ART one day. We don't have whether this is a molecule or something else we need it is a proof of concept. So this particular researchers concluded stating that, so now there is a hope that there might be a cure one day. There are molecules available, whether this is a molecule or something to be fine-tuned on the similar proof of concept, thereby we can stop ART one day. At this time, don't stop ART. You have to continue this on a long run. I want to wind my talk stating that about the cure. As we all know that there are 2 patients in the history have already been cured of HIV, but not conventionally through antiretroviral drug, but I'll call by accident, by giving stem cell therapy from CCR5 deletion donor. So these are the patients. One is a Berlin patient and is a London patient who had already been cured. Now the third case recently had been seen. So this is again a patient. I'll just walk through the history and in my talk. It's a 59-year-old female diagnosed in 2013 who had acute myeloid leukemia, where again, this patient, where they had given a CCR5 deletion donors cord blood, they did a transplant, stem cell transplant, and also they have done a chemotherapy with this particular compound, and they have seen a durable AML remission. And also, they have interrupted the therapy. Now, we have been stopped for almost 37 months after the post-transplant and the chemotherapy. And they have seen continuously undetectable viral load. And also, now they do what is called 2LTR into the integrated DNA. They've seen they are being seen in one particular patient, were not able to see even up to 12 weeks. These LTRs were detected only at week 12 post ATI. So that means there is another concept that where this has got something to do with that, but again, it's not practically possible in our routine practice because this stem cell therapy has its own issues on morbidity and mortality and expensive. You need to get CCR5, but on again, this proof of concept can be used in a very different way. Also, in this particular participant, they have seen there is a loss of HIV1 specific antibody response. So that means the virus has completely gone, even their antibodies also been gone. It's been seen, something a third case which had been cured. The investigators concluded stating that they have some proof of concept to do this. I'm going to conclude my talk now stating that HIV today persists throughout the body despite with whatever antiretroviral group. The several factors contribute. The sterilizing cure has occurred only 3 patients, the third patient which I showed today now. But this method is definitely not scalable. It will not be possible. For curing, kick and kill strategy can activate HIV replication, but does not show reduced HIV DNA. There might be a combination approach as shown by me in one of those studies of combining like drug like remdesivir along with the BNAbs, along with the ART. Something might be possible. There is proof of concept, but we don't have an answer at this time. But only answer we have is which we are all doing. A functional cure, that is suppress a virus less than 20 copies or target not detected, That's something where you all have to look forward to do that. We have a robust drug PLD to it. I also like to end, now we are in the COVID era, along with the public health message of hand washing, mask, and avoid gathering publicly. What other message you give it to your people living with HIV who are coming to your clinic? Make sure that they adhere to the antiretroviral drugs. Today, based on reviews, HIV is not a cofactor for COVID disease progression if they're continuing their antiretroviral drugs, have a suppressed viral load, if all their opportunistic infections are suppressed. There are data available from South Africa. If they're not taking the drugs, if they have any opportunistic tuberculosis, COVID can be very severe. So you counsel the patients, all of them, at this time. So now we are going through the very difficult era, and also we might expect a fourth wave anytime soon. And don't change your currently effective therapy from DTG to a PI-based therapy. Because earlier we said lopinavir might work. Now you might see that now Paxlovid is going to come up to in India, which is ritonavir boosted with the nirmatrelvir. So again, don't think that our protease inhibitors, what we are going to use, going to help these COVID patients, and don't change this. What you have to do is they develop a COVID, treat them conventionally, same like how you treat a non-HIV COVID patients. There is nothing different. But again, significant number of patients with HIV also have other comorbidities like diabetes, hypertension, and other comorbidities, which are major cofactors for COVID disease progression rather than HIV. Also counsel in your practice, make sure that they take their diabetic medication, exercise, and keep control their blood pressure, because it's very important, even if they develop a COVID, they will not cause any major issues. Also from our own studies, published studies from Chennai, someone who has got HIV and COVID, they have a similar disease progression as compared to people who don't have non-HIV. And very importantly, stress on the COVID vaccination, as well as a booster, which are available. Again, all immunocompromised people should be boosted. I'll stop my talk at this time, and thank you again for the opportunity, and thanks for the patient hearing, and I will be happy to take any questions if you have. Thank you.
Oh, thank you very much, sir. It was a great intellectual feast. We have started with a lot of practice-changing studies, and we end with the cure and remission kind of a things. And very importantly, your commentary for all this study that makes this session more interesting and worthwhile. So we discussed about the NADRA, we discussed about the VISEND, then we also discussed about the optimizing the NRTIs and also a SALSA study. And it's very interesting for me to know that the study which has done in the SALSA, the result that you have presented, there's no impact of the baseline resistance in that patient. So those who have been switched to the dolutegravir and lamivudine. So that's a really reassuring. We also discussed about long-acting injectables, and we also come to know that 2-monthly or bi-monthly regime is also available, and that's going to help us. And also we discussed about these calibrate capella studies and how the future guidelines are going to change in terms of we are reducing the exposure of the patient, making more long-acting drugs, having injectables with a 2 months frequency, or maybe at 6 months also. It is also interesting that neurocognitive impact of the disease and intensification of the drug or adding more drugs are not going to help or add value. That's also very important to understand. And what you presented 3 cases where the remission or cure, you can say, that's also quite well interesting. So, sir, I have one question before we go to all these kind of questions. So, particularly, I'm more interested about the SALSA study and the study results which you have presented. So, lamivudine and dolutegravir. Lamivudine is a slightly old molecule which has been used in many patients, and we are always concerned about the baseline resistance in this kind of a patient. So now there is no worry about the baseline resistance, and we can safely switch to the dolutegravir and lamivudine?
So I think what I made a point was they should have a suppressed viral load. I think that's very important.
Okay.
If they have a suppressed viral load and you feel that there is a risk of using tenofovir or any NRTI on a patient, particularly on the renal and as well as on the bone, then there will be a case note to switch. And also you should make sure that they should be hepatitis B negative, and they should not have tuberculosis, because now we have robust data. That's what I presented at this, this webinar. And also now it is available as a FTC, as a TWINAQT, 3DC and DTG. So this is time to make this switch.
That's very important, sir, and that's a really practically relevant. in real life scenario. So what you have suggested. So one more question from my side. I've seen this data of you presented with Calibrate and Capella of lenacapavir. But sir, do you feel this is a sample size was slightly low? Because I've seen every arm it was 50, around 50, or it's a
I think these are the studies on phase 2. Now phase 3 has come.
Yeah.
So now I think the larger studies are already been ongoing, or with the larger numbers which I have not presented. Again, in Montreal meeting, in the IAS conference, there will be some updated data will be presented. We should wait for. I think this molecule will take some more time to get into clinical practice as well as in the guidelines. So on looking at all those development from the phase 1, phase 1B data, and phase 2A and phase 2B, and the early phase 3 data very clearly shows that it is robust. So I think every possibility this molecule will survive. As you know that from your manufacturing perspective, where there are several molecules were being developed, many of them get killed in many of those phase 1 and 2 studies. But this has survived and very robust and a new class of drug. And very importantly, it's a long-acting, preparation is robust.
See, always it is welcome of anything which is long-acting. So we'll see some of the questions posted by our panelists. So there's one question which says that Dr. I could see. So there's a question by Dr. BJ Bora. What he says that is hyperglycemia is a common side effect of dolutegravir. So he has noticed in some of his patients. So he's curious about this.
Sure. So I didn't talk anything about the side effects of various drugs because this is a webinar pertaining to CROI update. So dolutegravir itself, as I said, have shown increase in weight from clinical trials on advanced study, and as well as a study which I showed on VISEND. Also, many of us have seen in our clinical practice. But don't assume that it's done only by dolutegravir. With all the integrase inhibitor, there are data available from bictegravir from North America. There are very nice reviews that have been shown, both with the elvitegravir and bictegravir and dolutegravir weight gain had been seen. But more this weight gain issues had been seen with dolutegravir, particularly in sub-Saharan Africa, mainly in women population. Of course, we are also seen in the Indian population, but we need a little more studies on that. Is it either the drug alone or combination with the TAF as shown in the advanced study as well as the VISEND study? Or there are some individuals who have got a susceptibility to do weight gain, because of this DTG. We have seen that with the favorants, not everyone develop a neurocognitive effect, some of them because of the certain HLA predisposition. So I think that type of studies are now planned because in dolutegravir is a robust molecule, so which has got a huge use. It can be given in pregnancy, in children, and as well as in tuberculosis. But your question on hyperglycemia, so we have seen this in people where blood sugar shoots to 300, 350. So again, when they are taking the conventional anti-diabetic drugs, it doesn't come quickly. So again, there are a lot of now studies have been planned, whether it is an asymptomatic hypertriglycememia or it is something like new onset of diabetes or anything. I think these are some of the things. At this time, we have data like I think anything what you see in your practice, we are also seeing that better to document, closely monitor, closely work with your diabetologist. I think this will be very important, particularly data generated from India, because we are an epicenter for diabetes, and significant number of our patients have diabetes because they live longer, not alone because of this drug, because of HIV also. There are data showing that HIV induces inflammation causing diabetes or accelerated aging, and also our own genetic makeup, our food habits, and all those, I think along with the DTG producers, I think we need to collect similar data, whether it is really diabetes or as something asymptomatic hypertriglycemia, which has been observed.
So thank you very much, sir. Another question posted by the same doctor, whether dolutegravir and lamivudine can be started in ART-naive patient, and should we use that? So
at this time, we have some data from trials, but I won't recommend it, but it's not recommended part of the guidelines because first you need to know at the baseline whether they are hepatitis B or not. And also we need to rule out about tuberculosis. And again, we don't do routinely baseline viral load. So there are also data shows that someone viral load is very high, more than 500,000 copies. So this may not be effective. That was been seen in that naive studies. So because of all this concern at this time in our setting, particularly in India, so since